Imagine celebrating your 40th birthday. You're blowing out the candles, feeling like you have a solid handle on your body, and assuming your childbearing years are just naturally winding down.
Right. The gentle fading of the light.
Exactly. But hormonally, your system is actually gearing up for this grand finale that's so chaotic, your chances of having a twin pregnancy literally just tripled. Welcome to the paradox of perimenopause.
Yeah, it is easily one of the most misunderstood phases of human biology. We tend to think of the end of fertility as a linear decline, but clinically, I mean, it looks much more like a massive fireworks display right before the show ends.
Which is exactly why we're taking a massive stack of medical literature today for this deep dive.
Right.
We've got official guidelines from the NHS, the National Institute for Health and Care Excellence, the British Menopause Society, and clinical data from Goldman Labs. We are cutting straight through the murky diagnostic waters today.
And it is desperately needed, honestly.
It really is. Our primary mission today is answering one of the most frustratingly debated questions in women's health. If you are over 45, how do you actually know you've hit natural menopause? Like, how many consecutive months without a period confirms it? And, more importantly, how does that number change your approach to fertility and contraception?
So the clinical guidelines are remarkably strict on this, mostly because the stakes are so high. If you rely on outdated myths or misinterpret the body's signals during this window, it leads to a staggering amount of mismanagement, anxiety, and frankly, a shockingly high rate of unplanned pregnancy.
Oh, yeah, absolutely. And because the diagnostic landscape is so prone to misinterpretation, the medical community had to draw a really hard biological line in the sand. Looking at the NICE guidelines, they establish a very specific threshold. If you're over 45, the definitive diagnostic criteria for natural menopause is 12 consecutive months without a menstrual period, assuming you're not using hormonal birth control, of course.
Yeah, yes, exactly. 12 uninterrupted months is the gold standard. Just to put the age parameter into context, the average age for reaching menopause in the UK is 51. But the normal distribution curve is wide. It spans anywhere from 45 to 55.
Okay, so a whole decade of variance.
Yeah, a huge window. The data indicates that by age 54, roughly 80% of women will have naturally stopped menstruating. So the guidelines specifically target that over 45 demographic because it represents the prime window where this natural shutdown happens.
But wait, waiting an entire calendar year, checking off months on a calendar to prove a biological negative, that feels incredibly archaic. I mean, modern medicine loves a biomarker, right? If your thyroid is sluggish, they run a TSH blood test.
Exactly, or an A1C for blood sugar.
Right. So the immediate assumption for anyone used to modern diagnostics is that a doctor can just, draw a vial of blood, check your menopause hormone levels, and hand over a definitive yes or no. Why wait a year?
And that assumption leads directly into what the British Menopause Society has spent years trying to dismantle. We can call it the FSH myth. The biomarker you're talking about is follicle-stimulating hormone, or FSH.
Okay.
But to understand why relying on an FSH blood test for a, say, 48-year-old woman is practically useless, we have to look at the body's internal feedback loop.
You mean the HPO axis, right?
Yes, the hypothalamic pituitary ovarian axis. Think of the pituitary gland in your brain as a factory manager.
Okay, I like this. So the brain is the manager.
Right, and the ovaries are the factory floor. The ovaries contain follicles, which are the workers responsible for producing estrogen. Throughout your reproductive life, when you have plenty of viable follicles, estrogen production is robust.
The factory is humming along.
Exactly. The brain senses this high level of circulating estrogen, is perfectly happy with the output, and communicates with the ovaries using a quiet, steady, chemical voice. That voice is FSH.
But biological aging means women are born with a finite ovarian reserve. By the time you hit your mid-40s, those follicles are undergoing a natural rate of programmed cell death. So the factory is rapidly losing its workforce.
And as the number of viable workers plummets, overall estrogen production begins to drop. The pituitary gland detects this systemic shortage and immediately tries to stimulate more production. Basically, the manager starts shouting at the factory floor.
Just yelling for more estrogen.
Literally. The brain pumps out massive amounts of FSH, trying to force the few remaining stubborn follicles to mature and release estrogen.
Okay, so an elevated FSH level in the blood just means the brain is shouting, which honestly seems like it would be a perfect indicator of ovarian decline.
Well, it indicates decline, yes, but it does not indicate menopause. The crucial flaw here is the sheer volatility of the perimenopausal period. Those remaining follicles, they don't just quietly give up, they are erratic.
They're fighting back.
They are. The brain might shout loudly with high FSH for weeks, And suddenly, a cluster of those remaining follicles actually responds. They produce a massive surge of estrogen.
Oh, so the brain senses the estrogen and thinks, problem solved.
Exactly. It assumes the factory is fully operational again, and the FSH levels plummet right back down to a normal quiet range.
Meaning a blood test is nothing more than a snapshot of a highly unstable system. I mean, you could have your blood drawn in March, show elevated FSH, and a doctor declares you menopausal.
And then in April, your follicles sputter back to life, estrogen spikes, FSH normalizes, and you get a very heavy period.
Wow, that is wild.
It is. This extreme fluctuation is precisely why the NICE guidelines explicitly state that for women over 45, doctors should not use FSH blood tests to diagnose menopause. It wastes medical resources and, worse, provides a false sense of finality. The diagnosis must remain purely clinical.
So it really has to be grounded entirely in physical symptoms, like hot flushes, night sweats, joint pain, and the tracking of that uninterrupted 12-month cessation of bleeding. Which brings us to a really dangerous assumption. If you've been tracking your cycle and you go, say, 8, 9, or even 10 months without a single period, the logical leap is that the factory is permanently closed. You assume your fertility is effectively zero.
And believing that a prolonged gap between periods equates to sterility is exactly what drives the astonishingly high rate of unintended pregnancies in older demographics.
The numbers on this are staggering. Up to 75% of pregnancies in women over 40 are unplanned, and roughly 27% of conceptions in this bracket result in termination.
Because the biological reality is that ovulation persists much longer than the bleeding patterns suggest.
Yeah, the Goldman Labs clinical guide paints a wild picture of how stubborn the reproductive system actually is. Up to 5 years before that final menstrual period, ovulation still occurs in nearly 88% of cycles.
Yes, and even when you are within just 1 year of the final shutdown, when your periods might be spaced 6 months apart, ovulation is still happening in roughly 23% of those rare cycles.
So nearly 1 in 4 cycles in that final stretch still involves the release of a viable egg. You're still fertile even when the physical markers are practically gone.
Exactly.
It really reminds me of a dying campfire. You can sit around a fire pit for hours after the flames have disappeared. The surface looks like nothing but gray ash. Going months without a period is like looking at that cold surface and assuming the fire is completely dead.
While underneath, those core embers retain an immense amount of thermal energy.
Right. The remaining follicles are those hidden embers, and the fluctuating FSH levels that shouting from the brain act like sudden gusts of wind blowing through the fire pit. Out of nowhere, a surge of hormones hits those dormant embers and throws off a massive, unexpected spark.
An unpredictable ovulation event. It perfectly illustrates why the clinical threshold is a full 12 months. You just cannot safely assume the fire is extinguished until it has been starved of fuel for a deeply extended period.
And here is where we loop back to that opening teaser about twin pregnancies. Because sometimes that dying campfire throws off more than one spark. The biological mechanism behind the perimenopausal twin spike is fascinating.
It really is. It comes back to the concept of superovulation, which is driven by the pituitary gland's desperation. In a normal, youthful cycle, the brain produces just enough FSH to coax one dominant follicle to mature and release a single egg.
But in perimenopause, the brain is flooding the system with excess FSH, just trying to get any response at all.
Right, the shouting is so loud that it essentially acts like an aggressive dose of fertility medication.
Wow. That massive surge of hormones can actually rescue secondary follicles from their natural cell death. So instead of one egg maturing, the sheer volume of FSH forces 2, or sometimes even 3, follicles to rupture simultaneously.
Which is why the statistical probability of a natural twin pregnancy doubles by age 35 and triples by the time a woman reaches 40. It's a biological overcompensation.
So, keeping the campfire analogy in mind, we know the sparks are unpredictable. We've established the clinical standard for diagnosis is 12 consecutive months without a period for those over 45. The natural deduction here is that month 13 is the finish line. Once you hit a year, you can just throw away your birth control, right?
Actually, no.
Oh, really?
Yeah, the NHS guidelines introduce a highly specific, age-dependent protocol for seizing contraception, and it is definitely not a universal green light at month 13. The timeline is dictated entirely by a woman's chronological age at the exact moment she achieves that 12-month milestone.
Okay, let's look at the over 50 demographic first, since that aligns most closely with the diagnostic criteria we talked about.
So for women age 50 and above, the protocol is known as the 1-year rule. If you are 50 or older, you are required to continue using contraception for 1 full year following your final natural menstrual period.
Okay, so that perfectly mirrors the 12-month diagnostic rule for menopause. Once you hit the diagnostic threshold, you're cleared.
Exactly. But the guidelines pivot sharply for women who experience this transition earlier. If a woman achieves 12 months without a period and she is under the age of 50, the requirement doubles.
Wow, so that's the 2-year rule. They have to maintain contraceptive cover for 2 full years after their last period.
Yes, the 2-year rule is critical for younger women.
Because younger bodies have a much higher threshold for completely shutting down. Chronological age plays a massive role in ovarian stubbornness, right?
It really does. In a woman under 50, those remaining follicles have a stronger survival mechanism. It can enter a prolonged state of dormancy rather than dying off completely.
So they just go to sleep.
Exactly. Clinical data shows a significantly higher incidence of the ovaries unexpectedly sputtering back to life and triggering spontaneous ovulation, even after 14 or 16 months of having no periods. So the 2-year rule provides a statistical buffer against that biological resilience.
Okay, that makes sense. But regardless of resilience, the NHS guidelines do establish a universal finish line, an ultimate biological ceiling where spontaneous conception drops so close to zero that you don't need contraception anymore.
Yes, the universal cutoff is age 55. Upon reaching 55, all women are advised that they can safely cease using contraception, no matter what their current bleeding patterns are.
So even if a woman at 55 is still experiencing an occasional erratic cycle, the underlying egg quality and the endometrial environment make a natural conception exceptionally rare.
Right. Over 90% of women have naturally transitioned through menopause by 55 anyway. The risk-benefit analysis of continuing hormonal contraception at that age overwhelmingly favors just stopping.
Which introduces, I think, the most glaring logistical flaw in this entire diagnostic process.
The masking effect.
Yes. The absolute foundation of everything we've discussed, the 12-month diagnosis, the 1-year and 2-year rules, it all relies on a woman being able to accurately track her natural cycles. But millions of women in their 40s and 50s are on hormonal birth control that completely alters their bleeding patterns.
Yeah, in clinical practice, hormonal contraception effectively draws a chemical curtain over the natural behavior of the ovaries. It overrides the HPO axis.
Let's examine the standard combined oral contraceptive pill, which has both synthetic estrogen and progestogen. Because it uses a schedule of active pills followed by a placebo week, it generates a monthly bleed.
But it's vital to understand that those are withdrawal bleeds.
Oh.
They're driven entirely by the sudden drop in synthetic hormones when you take the placebo.
Right, they are not natural ovulatory cycles. A woman could be fully menopausal, her natural ovarian function totally depleted, but the combined pill will just keep orchestrating that monthly withdrawal bleed.
Exactly. So the bleeding provides zero diagnostic value regarding her actual menopausal status.
This is why the UK medical guidelines issue a hard stop on the combined pill for this demographic. Women are explicitly advised to cease taking the combined pill at age 50. And that mandate to stop at 50 is rooted in cardiovascular physiology. The synthetic estrogen in combined pills has to be metabolized by the liver through what's known as the first pass effect.
Which artificially upregulates the liver's production of clotting proteins.
Exactly. Proteins like fibrinogen. Now, a 25-year-old circulatory system can generally handle that without issue because the blood vessels are highly elastic.
But as a woman reaches 50, her vascular endothelium naturally stiffens.
Right. Combining age-related vascular changes with the liver pumping out excess clotting proteins creates an unacceptable spike in the risk of deep vein thrombosis, pulmonary embolisms, and strokes.
So at 50, doctors transition the patient to a safer progestogen-only method or a non-hormonal option.
Entirely to mitigate that cardiovascular risk.
Okay, but progestogen-only methods like the mini pill, the implant, or the Mirena coil, they create an even more extreme version of the masking effect. Because of how progestogen interacts with the uterine environment, it stabilizes the endometrium and keeps the lining of the womb constantly thin.
And if the lining never builds up, there is nothing for the body to shed. Consequently, these methods frequently eliminate bleeding altogether.
Which means a 51-year-old woman with a Mirena coil might have 0 periods for 5 years, but she has absolutely no way of knowing if it's natural menopause or simply a mechanical side effect of the device.
She's navigating the transition entirely blind.
She is, and this highly specific scenario is the single solitary exception in the medical guidelines where the heavily criticized FSH blood test is actually recommended for women over 50.
The exception to the FSH myth. Let's break down exactly why the test is valid here, but useless everywhere else.
Well, if a woman is over 50, using a progestogen-only method, experiencing no periods due to masking, and wants to know if it's safe to remove her contraception before 55, a doctor can draw an FSH level.
And the critical difference is that progestogen-only methods do not suppress the pituitary glands shouting, right? Not the way the combined pills synthetic estrogen does.
You've got it. The HPO axis is still communicating. The factory manager in the brain is still sending out signals, and the progestogen isn't muffling the sound.
So the blood test can actually read the FSH levels accurately. And if the lab results show an FSH level elevated above 30 IUL, it serves as a clinical indicator of significant ovarian insufficiency. The factory is shutting down.
Exactly. But the crucial caveat that trips up so many patients is that an FSH reading over 30 does not mean you can walk out of the clinic and throw away your mini pills that afternoon.
Because the campfire is still a threat.
Yes, an elevated FSH confirms the transition, but it does not guarantee immediate sterility. The guidelines mandate that upon receiving that elevated result over 30 IUL, a woman must continue using her progestogen-only contraception for one additional full year before she can safely stop.
It always routes back to the waiting period. Even with biochemical proof of ovarian failure, the biological resilience of the reproductive system demands a 12-month buffer.
The transition is a slow biological cascade, not a sudden switch.
So we have dissected a massive amount of clinical data today. Let me just quickly synthesize the core takeaways for you regarding menopause, age, and fertility. First, the diagnostic gold standard. If you're over 45 and not on hormones, natural menopause is confirmed solely by 12 consecutive months without a period.
Right?
Second, avoid the FSH biomarker trap. Perimenopausal hormones wildly fluctuate, so blood tests offer useless snapshots that cause more confusion than clarity. Diagnosis should be grounded in symptoms and time.
Exactly.
Third, respect the perimenopausal campfire. Erratic ovulation persists long after periods become irregular, driving a high rate of unplanned pregnancies and tripling the probability of twins by age 40 due to superovulation.
That's a huge factor.
Fourth, the timeline for stopping contraception is strictly age-dependent. Wait 1 year after your final period if you're over 50, and 2 full years if you go through menopause under 50. But everyone crosses the universal finish line at age 55.
That's the hard cutoff.
And finally, hormonal contraception completely masks the timeline. The combined pill induces fake bleeds and must be stopped at 50 due to clotting risks. Progestogen-only methods eliminate bleeding, and if you are over 50 using one, this is the one instance an FSH test over 30 IUL can help trigger your final 1-year countdown.
It's a rigorous framework, but it strips away the guesswork that puts so many women at risk. And, looking at the entirety of this medical data, there is a profound, almost philosophical reality embedded in the way we're forced to diagnose this transition.
It really fundamentally changes how we view medical certainty.
It does. Menopause is one of the only major biological milestones in human life that is diagnosed entirely in the past tense.
Wow, yeah. Because the clinical definition requires the passing of 365 days of absence to confirm, you only officially know you have reached the milestone a full year after it actually happened.
Your final period, the precise singular moment your reproductive years end, comes and goes, and you are completely unaware of its significance until a year later. It forces you to exist in a liminal space of profound uncertainty for 12 whole months.
Every time a month passes, you're left wondering if the campfire is truly out or if another spark is coming. We are so conditioned by modern medicine to expend immediate confirmation. We want the instant read of the thermometer or the ultrasound image.
But our biology actively resists that demand for instant gratification here. The HPO axis demands that we sit in the mystery of the transition. I think it underscores why tuning into the nuanced, lived experience of your own physical symptoms and patiently tracking your body's patterns is vastly more powerful than chasing a static number on a lab printout.
You only truly see the destination once it is firmly in the rearview mirror.
Beautifully put.
Well, the diagnostic landscape might be muddy, and it forces us to live in the past tense, but understanding the mechanics behind the mystery makes navigating it infinitely less intimidating. Take these clinical insights, use the 12-month rule to advocate for your own health timeline, and bring this knowledge into your next clinical consultation. Keep questioning the biology, keep learning how your system operates, and we will catch you on the next deep dive.